All right, good afternoon, everybody. This is Michael Beasley from the Yale School of Medicine. Thanks for everybody for making the time to join today. I knew today was going to be a little bit of a difficult draw, probably, because, guideline-directed medical therapy doesn't have the excitement for maybe some people that, LVAD management or transplant management might have. But this is something that's still very important for all heart failure clinicians to be knowledgeable about. And I'm going to try to go through the material here in a way that's interactive and fun for everybody, versus me just speaking about things that likely most of you already know. Again, we're using a different website today. I'm using a website called Mentimeter. To join the meeting so that you can participate, please either scan the QR code in the bottom left-hand corner of the screen, or go to menti.com and type in the code above, 7680-4932, and that will allow you to participate. Okay. All right, one last reminder about how to join. The more people we get here, the better, and off we go. So just to make sure that everybody is able to use the device or everything appropriately, go ahead and pin your current location on the map. If you are not in the continental United States, you can place yourself out in the Atlantic or Pacific Oceans, depending on which direction you might be. And we'll see where we're drawing people from today. So it looks like, predominantly Northeast, or, us being on the Eastern time zone, that's not surprising. All right, we got Texas represented.
California.
California, nice. All right, so we're getting all over the country. So thanks everybody for taking the time here. All right, so our learning objective for today is, and this is coming from the advanced training statement for advanced heart failure fellows, is to know the evidence-based, including randomized clinical trial data supporting contemporary guideline-directed medical therapy. So I think the first thing, just to kind of, have a sense of clarity for everybody before we get into the larger part of the presentation, is to know exactly who are we talking about when we're talking about this patient group for which we're going to think about medical therapies. So as you know, through the most recent update to the heart failure guidelines, which was published in 2022, there are a variety of, and this predated the recent update, but this particular slide comes from that update. There's a number of stages of heart failure. Eventually, as part of this course, we will get into the nuances between these stages, as that is a learning objective on its own. But I just wanted to point out today that we are looking at patients that have stage C heart failure. So these are patients that have had either current symptoms or have had symptoms in the past, and then obviously have structural abnormalities in regard to their heart function that could be indicative or a cause of the symptoms that they are suffering from. So, in contrast, patients that have stage B heart failure, are patients that have some anatomical abnormalities, but they're not symptomatic. And then lastly, on the right side there, the patients that are symptomatic but don't, no longer tolerate guideline-directed medical therapies. Those are the patients that we put into that stage D category. The other thing that I want to talk about, or just bring to your attention, I guess I should say, is that there's a variety of ways that we can kind of classify patients within stage C heart failure. And the terminology that's been recommended for us to use is either new onset de novo. So those are patients that didn't have a prior diagnosis and are getting diagnosed either in the clinic for the first time when you see them, or more commonly maybe in the emergency room. Patients who've had resolution of symptoms, so this is always the victory that we're going for, that we've got them on great medical therapy. They were symptomatic and now they're back to their old selves, doing whatever they want to do without limitation. Persistent heart failure, these are patients that still have some degree of limitation, maybe, but not as bad as they did maybe, when they initially had an exacerbation or decompensation, but they're still limited at some point. Then worsening heart failure is a very interesting category. And these are patients that have had some type of episode where their overall trajectory or course of the disease is getting worse. And that means like maybe we've had to go up on the diuretic dosing, they've had a hospital admission, they're no longer tolerating guideline-directed medical therapy, so we're having to peel them off. All sorts of things. They need outpatient IV diuretic therapy. Those are patients that could be qualified as having worsening heart failure. And the reason why this is important is because some of the things that we're going to look at with indications for guideline-directed medical therapy does kind of play a role into where you would put them in, not only in what stage they're in, but also how symptomatic they may be. And then finally, we have to know that we're looking at patients that have had or do currently have a reduced ejection fraction. And what does that mean? Well, the current definition is heart failure with a reduced ejection fraction being an ejection fraction of less than 40%. But this also, applies to patients who have heart failure with improved ejection fraction, and that's somebody who's had an ejection fraction of less than 40% in the past, and then over time, often due to being on good medical therapy, they've had improvement in function, and now their ejection fraction is more than 40%, and they have to have at least a 10% improvement from their nadir to their current state to be qualified as having improved ejection fraction. So, what do you guys think of when you think of heart failure with reduced ejection fraction guideline-directed medical therapy? So you should be able to type something in on your device or on your desktop, however you're looking at the presentation. And, this could be, it's easy, it's boring, there's poor implementation, perfect. It's very confusing. I do it every day. Any other thoughts out there from the group? Timing and sequence. Okay, good. 4 pillars. Yes. Beta blocker, ACE inhibitor, ARB, SGLT2 inhibitor, aldosterone antagonist. Beautiful. What else do we got? Entresto. Okay. Novartis is happy that you mentioned that today. It's evidence-based. Yep, that's definitely true. We've got plenty of trials to look at. Highly underrated. Oh, I completely agree with you on that one. That yes, highly underrated. I've been practicing heart failure cardiology now for 4 years since I personally graduated from fellowship training. And I swear the thing that's been most remarkable to me is how many of these patients get so much better when you get them on great doses of GDMT. And it really is remarkable to see people go from having an ejection fraction of 25% to normalizing their ejection fraction after several months often, but being on good doses of GDMT for several months, and then they get really good outcomes. So I completely agree. Highly underrated. Absolutely. All right. Lots of medications. Yeah, that could be a problem too. Some patients get worried about pill burden. Sometimes we get worried about the total cost of drugs for the patients. That's access is a big problem because of cost and how much they need to take. And I've had a couple of patients in clinic this morning that have, I ask them what's on your agenda for today, or what are your priorities for the visit? And it's not uncommon where people are going to say, is there any of these medications that I can come off, right? Because they are taking so many medications, not only for their heart failure, but often for their other comorbidities as well. All right, well, thank you so much, everybody, for chiming in there. So, uh, let's see. So what we have here is a figure that depicts all of the trials that have taken place over the years that have looked into the possible benefits of these medical therapies for heart failure with reduced ejection fraction. So, like I said, I'm not going to spend your valuable time going through these and one by one and kind of pulling out all the data that's there. Now, if you want to be a heart failure fellow or be a healthcare professional that takes care of patients with heart failure, it's important to really have an understanding of this trial data. But we have a better way that we can spend our time today. But just to give you an overview, the first things that came out in the 1980s and early 90s were the vasodilators, and prior to that time, they were treating patients often with digoxin and hydralazine and diuretics. But it wasn't until the mid 1980s where there was a thought that there could be some role of neural hormonal blockade as a means for treating heart failure. So you had the consensus study, you had the SOLVE trials, and these, were the first trials that looked at renin-angiotensin system inhibition as a possible mechanism for treating heart failure with reduced ejection fraction. Then you moved into the late 90s, early 2000s, and then it came about the beta blocker trials, MERIT-HF, Copernicus, Comet. These was really kind of an incredible idea at the time. People previous to that had thought that beta blockers were incredibly harmful in heart failure with reduced ejection fraction. But through these trials, we found that there were beta blockers that not only helped the ejection fraction improve over time, but reduce mortality. And as have become a pillar of our therapy at this time. You moved more then towards the late 2000s, and you have device therapies, but you also have the introduction of angiotensin system neprilysin inhibition, which is sacubitril valsartan, or by brand name Entresto, and the paradigm trials that supported its use as a renin-angiotensin system inhibitor that then has come to supersede the other RAS inhibitors that are either ACE inhibitors or angiotensin receptor blockers. And somewhere there in the middle, I lost the mineralocorticoid receptor antagonists. You had the RAILS trial, which is there in 1999, Emphasis HF in 2011. Demonstrated the benefit of aldosterone antagonism. And then more recently, as we all know, since we're, this is what we love to do, we've had the SGLT2 inhibitors, or maybe what we should say now is the SGLT inhibitors, because we're noting that there are SGLT1 and 2 inhibitors that also potentially have clinical benefits. So that nomenclature may be changing as we move forward. So, if you really want to kind of get the good grasp on where, the data, kind of how it was put together and really used to create this most recent edition of the guidelines, I think you really only have to read one section of the guideline, which is section 7.3. And that goes, and it's probably, looked at it myself to, prepare for this talk, maybe 6 to 7 pages. It's not very long. And it talks, just in general, what are the consensus, recommendations for use of these drugs in the different classes, and then kind of gets a little bit into, where the supporting data comes from. And then obviously you could always follow the citations if you wanted to learn more about that. But I think if you would be interested in reading, learning more about that, that's where I would recommend you going. But for today, we're going to test your knowledge and see how well do you guys all know HFrEF GDMT. So if you think you're ready and you're a heart failure professional, I hope you're up for the task. So here we go. And we're going to have the HFrEF GDMT knowledge competition. So again, if you're just joining, the ways that you can participate in this competition are to either go to menti.com and enter the code 76804932 or scan the QR code that you see on the screen. And I'm just going to give you about 10 seconds here for anybody who's scrambling to grab their phones or entering. And if we're all good, let the games begin. Okay. All right, so you're going to be asked a series of multiple choice questions. You, on your device, should be able to select the best answer out of the available options. You will earn points not only for a correct answer, because I'm sure we'll get many correct answers, but also if you answer quickly, the computer is going to recognize that and give you bonus points. So it's how fast you can answer and how accurately you can answer. All right, so we got 7 players, 8 players in the game. Anybody else want to join? All right, well, here we go. Which of the following statements about RAS inhibition is false? New York Heart Association class 2 or 3 on an ACE inhibitor or ARB must be transitioned to an ARNI. An ARNI is recommended as de novo RAS inhibition in hospitalized heart failure. An ARB is recommended for ACE inhibitor cough or history of angioedema. ARNI to ACE inhibitor needs 36 hours of wait time, or does not need 36 hours of wait time. Anybody voting there? All right. So the answer was that the false statement was that you do not need 36 hours of wait time when transitioning from an ARNI to an ACE inhibitor. I think everybody knows that when you're going from an ACE inhibitor to an ARNI, you have to wait 36 hours between doses. But probably less well known is that if you're going the other way around, say, for example, somebody's not tolerating the ARNI and you want to put them on an ACE inhibitor, you also need to wait 36 hours before you start that ACE inhibitor. All right, so let's see how we're doing here. So looks like Thomas is in the lead with Frosty coming in second. All right, we'll go to the next question. All right, we got 10 players in now, good. All right, here we go. Answer fast to get more points. Which of the following statements about beta blockade is true? Beta blockade initiation can be delayed or withdrawn for asymptomatic patients. Abrupt withdrawal of beta blockade therapy can lead to clinical deterioration. The benefit of beta blockade in HFrEF is a class effect. Which of those statements is true? Oh, great. Everyone has voted. Let's see what we got. Oh. All right. Good job. 9 out of 10. Abrupt withdrawal of a beta blocker can lead to clinical deterioration. Yes. If you have somebody on a high dose of beta blocker, you do not want to stop it abruptly. I have taken care of a patient in our hospital where another physician abruptly stopped their beta blocker, and that person developed stress-induced cardiomyopathy and was in the CICU on a balloon pump. So it can be very dangerous. Wean it if necessary. All right, so here's the leaderboard. All right, so looks like, oh, it's very close. All right, Thomas is still there up at the top. Joanna did a good job there. So we're going to go here to the next question. All right. Which of the following statements about mineralocorticoid receptor antagonism is false? MRA may be initiated in New York Heart Association class 2 to 4 patients. MRA may be initiated so long as eGFR is greater than 30 and the potassium is less than 5. MRA must be stopped when the potassium level rises to more than 5, or eplerenone is less likely to cause side effects than spironolactone. All right. So 50% of y'all got that one. So the MRA must be stopped when potassium is greater than 5. That is not true. If the potassium raises to greater than 5, you can definitely still continue the mineralocorticoid receptor antagonist. The guidelines say that if it rises to greater than 5.5 is when you should start thinking about maybe stopping it or holding it. But greater than 5 is not a problem. Looking at the other ones, the MRAs are actually indicated for patients with New York Heart Association class 2 to 4 symptoms. And eplerenone is less likely to cause side effects than spironolactone. So, less likely to cause gynecomastia and also then vaginal bleeding in female patients. All right. So just so you all know, we have 10 questions here. So looking at the clock, we'll go get through these pretty quickly and get you back to your afternoon. So question 4. Which of the following statements about SGLT inhibition is true? The patients in trials that showed benefit of SGLT2 inhibitors in HFrEF had New York Heart Association class 2 or 3 symptoms. To prevent volume depletion, adjustment of diuretics may be needed. Trials for the benefit of SGLT2 inhibitors in HFrEF excluded patients with a GFR of less than 30. Sotagliflozin, which is an SGLT1 and 2 inhibitor, did not show clinical benefit. So which of these is true? Perfect. So, patients do run the risk of possibly getting dehydrated. Therefore, you might need to redose your loop diuretic if they're on a loop diuretic when you start an SGLT inhibitor. Patients in these trials had New York Heart Association class 2 to 4 symptoms. And you can, in the trials where empagliflozin was studied, they included patients with a GFR down to as low as 20. So my personal practice is, and for colleagues say it probably really doesn't matter, between empagliflozin or dapagliflozin. But if you're trying to just kind of really do what was evidence-based, for me, if I get patients that are nearing a GFR of 30, I usually transition them to empagliflozin since at least the trial showed it was safe down to a eGFR of 20. All right. All right, Omar is in the lead. Which of the following is not a target dose for RAS inhibitors when used to treat HFrEF? Not a target dose. Lisinopril 20 milligrams once daily, losartan 100 milligrams once daily, sacubitril valsartan 97-103 twice daily, enalapril 10 milligrams twice daily, or valsartan 160 milligrams twice daily. Which one of these is not the target dose? All right. So losartan's target dose is 150 milligrams once daily. Sacubitril valsartan, enalapril, valsartan, those are all accurate. Those are what the target doses are. Probably the one you might be more surprised at is that valsartan's 160 twice daily. And then lisinopril can be anywhere from 20 to 40 once daily. So that is actually the target dose. You could finish at 20. Frosty for the win on that one. All right. which of the following is not a target dose for beta blockers? So 4 of these are correct. 1 of them is not. Bisoprolol 10 milligram once daily, carvedilol 25 twice daily if less than 85 kilos, carvedilol 50 twice daily if greater than 85 kilos, carvedilol 80 once daily, that's the extended release, or metoprolol succinate 150 once daily. All right. So the trials where metoprolol succinate were studied actually had a mean target dose of like 158 milligrams or something like that. This is obviously, it was an average, so that's why it's kind of weird. But the guidelines actually recommend you try to get patients up to 200 milligrams once daily. And the other 4 are indeed correct. Bethany, good job. All right. All right, question 7. So which of the following is a target dose for MRAs? So this is the opposite of what we were doing. Which one of these is correct? Spironolactone 25 once daily or eplerenone 25 once daily? Whoop. Oh, everybody got it wrong. Oh no. All right, so actually for eplerenone, you're supposed to go to 50 milligrams once daily. And for spironolactone, it can be anywhere from 25 to 50 according to the guidelines. So eplerenone's a little bit weaker, is the way I kind of think of it. And I do transition folks from spironolactone to eplerenone for side effect issues, and you should try to go to a higher dose when you do that. So no points for that one. All right, 3 more to go. Which of the following is a target dose for SGLT2 inhibitors when used to treat HFrEF? Dapagliflozin 5 or empagliflozin 10? Great. Everybody's voted. We get 100% here. So empagliflozin 10 milligrams is the target dose. For dapagliflozin, you have a 5 milligram dose and a 10 milligram dose, but the 10 is what you use to treat HFrEF. For empagliflozin, there's also a 25 milligram dose that's out there, but that's the diabetes dose. So for HFrEF, we use the 10 milligram dose. All right, Frosty. All right, Omar's just behind, and then Manish is there as well. We got a pretty tight race there up towards the top. 2 questions to go. All right, see who can bring home the championship. Which drug class is not listed with the correct number needed to treat for all-cause mortality standardized to 36 months? So over 36 months, how many patients do you need to treat with this drug class to prevent 1 mortality? Is it 26 patients for ACEs and ARBs, 12 for ARNIs, 9 for beta blockers, 6 for MRAs, 22 for SGLT inhibitors? So which one of those was wrong? And it was ARNI. So actually, ARNI, the number needed to treat was 27. Yes, only 6 is the number needed to treat for MRAs, which I think is a great fact that most cardiologists don't realize. That's the lowest. And then everybody probably knows that beta blockers have a really good benefit too. So, when you look at this, I mean, in my practice, I really try to, get the beta blocker and MRA going, and because of this data here. I don't know if that's the right choice or not, but this has influenced the way that I think about prescribing and sequencing the drugs. All right, Thomas. All right, let's see what we got here. Last question. Here we go. which drug class is not listed with the appropriate corresponding value statement? So in the last issue of the guidelines, they said value statements, meaning like how affordable was the medication for the benefit that it delivered. So they said ACE inhibitors and ARBs was at a high value, were ARNI a high value, were beta blockers intermediate value, were MRAs a high value, were SGLT2 inhibitors an intermediate value. Which one of those is wrong? And that's correct. Beta blockers are high value. I think that the thing here I was trying to trick you with is if people might have been surprised that ARNIs were also high value because, as we know, they can be expensive for our patients. But according to their cost effectiveness analysis, they did find that ARNIs are high value therapies. So let's see what we have here at the end. And our winner is Frosty. Maybe we'll see Frosty this weekend as we're supposed to have a blizzard coming up here to the Northeast. So we'll see. Great job, everybody, for participating in the challenge. So just a few last minute things, and then everybody can go back to their afternoons. Here at the Yale School of Medicine, one of our fellows, general fellows, and a former internal medicine resident, Ray Hu is the cardiology fellow, created this website that helps you determine when is it appropriate to use various forms of guideline-directed medical therapies, and more specifically based upon renal function. So I'd like to plug that website for him. It's a fantastic tool. Also, I and Ralph Riello, who you guys met at our last lecture, and some of our trainees here at Yale recently published a paper talking about sequencing these drugs in HFrEF. This was published in Cardiology Clinics. I encourage you to check that out. And lastly, if you like heart failure, and I would encourage you to subscribe to the Heart Failure Beat. This is a podcast that I co-host with Priya Omapathy from Johns Hopkins University. And we have a monthly episode where we talk about hot topics in the field. All right, well, thank you so much. And I know we're past the hour, but if there's any questions, I'll sit on here for a minute. Otherwise, I hope you have a great afternoon, and we'll see you next week.
Thanks, Beasley. Great job, buddy. Very interactive.
Thank you, Dr.
Thank you,
Beasley.
Dr. Beasley.
Thank you.